Now.
Good afternoon, everyone. Today, I present a topic on a study of indication and outcome of modified implant dacryocysto-rhinostomy. As we know, dacryocystitis is common eye disease in ophthalmic practice after cataract. Treatment of choice for chronic disease dacryocysto-rhinostomy. Despite the fact conventional DCR most preferred surgery, it has still certain disadvantages like it is time-consuming procedure, nasal packing is necessary, require large size of ostium, bleeding and tissue handling is more. Then contraindicated in children and more than 80 year of age patient. There is probability of failure of surgery due to ostium occlusion from the membrane and granulation tissue formation. To overcome these difficulties, a new technique called implant dacryocysto-rhinostomy was introduced in 1985, but expulsion rate was 10% through nasal cavity. It has been again modified in 2010, aimed to obtain and maintain the patent passage between the lacrimal sac and middle meatus of the nose through the bony ostium. The new modified power implant intracystic implant made up of the silicone, which is providing maximum tissue compatibility and less thrombogenicity. It has collar with haptics and multiple holes at the proximal and distal end of the tube, and it is available in length of the 13 to 17 mm in length. Aim of the study to study the indications and indications of modified implant dacryocysto-rhinostomy and to evaluate success rate and complication of the modified implant DCR in patient with nasolacrimal duct blockage. A study was conducted in 65 patients at Mahatma Eye Hospital in 2014 to 2014 to 2016. Inclusion criteria was obstruction at nasolacrimal duct only. Patient agreeing with a 6-month follow-up period and age was 15 to 80 years of age. Exclusion criteria was active dacryocystitis, fibrous sac, granulation tissue or malignancy at the sac, bleeding disorder, immunocompromised patient. Patients were selected for the study according to inclusion criteria. After taking informed consent, this operation was performed by senior consultant under local anesthesia and GA in adults and children respectively. First, about 5 millimeter skin incision was made at the anterior lacrimal crest area, then expose of the lacrimal sac, then anterior lateral incision of the 3.5 millimeter long over the longer over this lacrimal sac area, then making the bony ostium in the lacrimal bone by the mastoid gauze. The newly fastened ostium with cotton swab soaked in mitomycin 0.4% for 3 minutes, then again irrigate with saline. Then implant is introduced in the cavity of the sac by the mastoid gauze. Implant is inserted in the cavity of the sac in such a way that collar with haptic lies in the cavity of sac, and checking the position of the implant by again irrigation by the normal saline. Then closure of the lacrimal sac, 1 or 2 stitches by the 6-0 suture, and closure of the wound skin by the subcuticular stitches. Then at the end of the surgery, on-table syringing was done to see the patency of the implant. Post-operative care, we give the oral and systemic anti-inflammatory drug for 3 days, local antibiotic drops and ointment, and decongestive nasal drops for 1 month, and special instruction give to the patient to avoid blow the nose for 6 to 8 weeks. A syringing was performed under local anesthesia in every follow-up up to 6 months. Result of the study was mean age was 31 to 74 years. Maximum cases were diagnosed as chronic dacryocystitis, followed by chronic DC with mucocele, and followed by chronic DC with lacrimal fistula. Average duration of surgery was 25 to 30 minutes. 2 cases were developed post-operative wound infection, and implant was expulsed in 2 cases due to forceful sneezing, and 1 case developed lacrimal fistula. Success rate was 93.84%. In our study, maximum cases diagnosed as chronic DC followed by acute chronic DC with abscess and lacrimal fistula. Similar study Gupta et al. Shows. And in our study, there is no intra-op complication were noted. And Gupta et al. Noticed longer duration of surgery, recurrence of the symptoms, pain and ecchymosis at the site of incision, and Chaudhary et al. Reported post-operative suture abscess, lid edema, incisional edema, and wound gap in conventional DCR surgery. So conclusion of our study was modified implant DCR is simple, safe, less time consuming, less complicated alternative surgical procedure for NLD blockage without disturbing the anatomical structure of the nasolacrimal passage. Thank you.